difficult to follow up these presentations. So I'm Dr. MohdIbn Abdul Malik. I'm from Isfahan Islamic Eye Institute, Dhaka, Bangladesh. So I'll be presenting endogenous endophthalmitis due to intravenous injection, a review of 3 cases. So a little bit of background for this. In Bangladesh, in our rural areas, we have where the doctors are less available, we have a concept of village doctors. So they have a quite common practice that when otherwise well patients have weakness, fatigue, or random complaints, they just randomly give an intravenous infusion of saline. I don't know whether it's the electrolyte gain, but the patients feel better, and it's actually a much more common practice than I realized after seeing these patients. So that's the background to this presentation. I have no relevant financial conflicts of interest to disclose. So the first patient I'll talk about was a 28-year-old female. She had a dimness of vision for 16 days in her left eye with mild redness and pain, no associated symptoms. She had a mild fever at presentation. There was no history of trauma. So she had a history of receiving an intravenous infusion 2 weeks prior to the onset of these ocular symptoms. She had no history of diabetes, hypertension, or any other known systemic disease. And she had no history of surgery or any procedures undergone. She had received just topical therapy prior to presentation at our hospital, moxifloxacin, prednisolone, and napifenac, with no significant improvement. The visual acuity was hand movements in her left eye. The other eye was normal. Our anterior segment findings revealed a UVL reaction with cells of 2+ with a posterior scenic eye. The fundus showed the absence of a red glow. I'll come to the color fundus photograph. We did an anterior segment imaging. We did a B scan. We did a complete systemic evaluations, which would include a complete blood count with ESR, RBS, creatinine, urinary, and of course, blood culture is essential in these cases to exclude bacterial and fungal organisms. So this is the, I don't have a pointer, but you can tell that there was a UVL reaction, and there's a posterior scenic eye with a festooned pupil. And you can see the reflex is pale. So this is the B scan of the patient. You can see that there is heterogeneous echocity of the vitreous cavity, which is more concentrated in the posterior pole. This was a feature that was common across all 3 cases, as you will see. I don't know if it's been reported as such, but this is what we found. So investigations actually didn't reveal much. There was a mild neutrophilic leukocytosis, which you can get in any fever. RBC, RBS, creatinine, all investigations were normal. The blood culture was also negative, surprisingly. There. So we managed it we clinically diagnosed it as a case of endogenous endophthalmitis. We went for hospitalization. We did antibiotics and antifungals, even though the blood culture was negative due to a high index of suspicion, and a significant proportion of these cases are reported to be fungal. So we went for ceftazidime, vancomycin, and voriconazole intravitreally. We continued the topical moxifloxacin, and we added an antifungal. We added a topical prednisolone. We added a ceftriaxone and vancomycin with oral antifungal cover. And we gave oral prednisolone. I know this is controversial, but we gave a short course, and we quickly tapered it over 2 weeks. We counseled the patient for immediate surgery because there was actually no other option here. So we went for, as we all do in endophthalmitis cases, we went for a vitreous biopsy followed by a parsplano vitrectomy. And we gave intravitreal antibiotics and antifungals. Sorry, I just wrote antibiotics, which was ceftazidime, vancomycin, and voriconazole. So successive follow-ups. The surgery was successful. I didn't include the video for the sake of time. I probably could have included it. But it documented a progressive improvement in visual acuity, with the most recent follow-up documenting a vision of 2/60. The patient unfortunately developed an ERM following surgery, but due to her phobia, she didn't want to go for ERM peeling. I'll show you the color fundus photographs. We stopped the systemic antifungals after 1 month because there was no evidence, and the vitreous tap was also negative for both bacteria and fungus. I know they say to continue it up to 6 weeks to exclude an occult infection, but and we also slowly tapered the topical steroids. So this, you can see that there is a thick epiretinal membrane over the macula. So this patient had a vision of 2/60. We actually advised ERM peeling in this patient. I'm sorry I didn't include the OCT in this, but the patient actually is unwilling to go for any further surgery. So this is her last follow-up as we documented it. The B scan looks very clear. Didn't really show the. So case 2, I'll just go in short. It was also a 26-year-old female, sudden dimness of vision in the right eye for 7 days, and this was also 1 week following administration of normal saline. She also had no other significant history, and the visual acuity was hand movements only, and we also went for a similar management protocol. So this was the anterior segment picture. You can see that there, in addition to the reaction, she had a fibrinous hyperpion in the hyperpion. So you can see that this B scan is also quite similar. There is heterogeneous echogenicity, which is more involving the posterior closer to the posterior pole. And the color fundus, we can see that there's something that is predominantly involving the posterior pole. That's why we took this picture. I think I missed one patient. Sorry. This is the third patient. It was a 28-year-old male. There was sudden dimness of similar presentation, sudden dimness of 7 days, 2 to 3 days following administration of normal saline. No other, so these patients say that they got normal saline. That's the history we got, so that's why I wrote it as such. There was no other significant history. The visual acuity was light perceptions only, and we also went for a vitrectomy in this case. So infectious endophthalmitis is we all know what it is, in which the internal structures of the eye invaded by microorganisms. Endogenous endophthalmitis is uncommon, and actually most cases have been reported in immunocompromised patients, not really immunocompetent patients. The right eye, some people have said it's more affected. Slides. So these are actually, as I already said, it's more common in immunosuppressed patients with chronic immune compromising illnesses, which include renal failure and diabetes, immunosuppressive diseases and treatment, which could be post-organ transplant, HIV, and long-term catheters, and urinary tract infections. So predisposing factors that have been postulated are invasive surgeries, intravenous drug abuse, and hepatobiliary and genitourinary infections and dental procedures. A group led by Esman et al. Found parenteral alimentation as the most common risk factor. However, that was mostly in a series of immunosuppressed patients. So as you can see, there really isn't a whole lot of investigations other than systemic ones that we can do to diagnose. It is essential to exclude a systemic illness. All the patients were referred to an internist after our surgery. I didn't mention that. And management should be in coordination with one to exclude anything that we might have missed. The investigations that we do are the ones that I already mentioned. vitreous and aqueous step is important. PCR is actually quite important in these cases. Unfortunately, due to limitations of our setup, we are unable to send all samples for PCR. It's both a case of cost and availability, unfortunately. So we go by our gut in a lot of cases, and that's why we went with the bacterial and antifungals. So principles of treatment, as with any endophthalmitis, to find and eradicate the source, to treat the disease. If there is onychroid retinitis, a lot of people advocate systemic therapy without vitrectomy. But vitreous infiltration, like vitreoretinal surgeons usually have a low threshold for vitrectomy. As it decreases the pathogen load, it decreases inflammatory mediators, allows sampling, and is thought to speed up the visual recovery. So notice I only spoke about the visual recovery of one patient. Unfortunately, neither of the other patients recovered their vision. That's why we like to speak of relative successes. We don't really like to talk about patients who don't regain vision. So only 1/3 of the patients actually got back useful vision, even with early vitrectomy. So the challenges in early identification and intravitreal treatment. Systemic therapy is essential. Pars plana vitrectomy has a diagnostic as well as a therapeutic role, and visual acuity, systemic debility. So as I said, a lot of patients in these cases are immunosuppressed. So in a lot of cases, pars plana vitrectomy is actually not possible because of the systemic condition of the patient. Although rare, we recommend that early diagnosis and management should include early vitrectomy, and referral to an internist is mandatory for ancillary management. I thank you for your attention.